Welcome, everybody. Welcome to another episode of PEM Rules. Special episode today. I am very happy to announce that I have my very first guest in PEM Rules, the Pediatric Emergency Medicine podcast. I hope you guys enjoy this session. Today we have a special guest that I'm very honored to have. Her name is Victoria. Victoria was my scribe when I was a beginning pediatric emergency medicine attending here in Florida. And a few months ago, she contacted me with a clinical question, and I said, that's a great question. I'm sure there's no one right answer. Why don't you look into this and tell me what you find, and maybe we'll have you on the show and interview you and see what you found, and maybe some other people can learn from this. So Victoria liked the idea, and she looked into it, and today we're going to talk about it. Victoria, thank you very much for joining us today. We all know that you're an excellent scribe. And I can't tell you guys how fun it is to have a hardworking, enthusiastic scribe who speaks Spanish, nonetheless, at the state of Florida. That's always very helpful. And again, Victoria was a great scribe, helped me a lot at the very beginning of my attending life. So we're very excited to have you, Victoria. Tell us a little bit about yourself.
Thank you so much. So I was born actually in Venezuela. That's why I speak Spanish, but I was pretty much raised in Florida. I went to UCF for my undergrad, and that's where I was working in the hospital with Yaron, and that's where I basically got my first experience in pediatric emergency medicine. And so now I'm a second year medical student going off to rotation soon. But I regularly listen to this podcast and I love hearing sort of like the clinical implications of what I'm learning in class. And working for your own was one of the best things that happened to me, I think, even before my career started, because it's really put me in the position where I think about doing less when it's needed and doing more only when it's needed. And so one of the recurring themes that he talks about in this podcast is sort of taking a step back and making sure you're not making the patient worse by what you're doing, and making sure that everything that you're doing has a purpose and that you're not doing it just to do it. So that's one of the biggest reasons, again, why I wanted to look into this. So basically, a few months ago, I had a lecture on anaphylaxis for one of my courses. And I started thinking about all the drugs that were presented to us. And it was basically everything that you constantly hear about associated to anaphylaxis. But I thought that it was the perfect opportunity to talk about in this podcast. And I regularly listen to this podcast, so it's really a pleasure to be here talking about it. But I know that this is one of your biggest points, is that when it comes to pediatrics, less is more. And so that's why I wanted to pose the questions and look into it a little bit.
Awesome. Well, thank you, Victoria. I'm not surprised by your dedication to go to med school, and during med school, I'm sure you'll be an excellent physician. I hope you'll become a pediatric emergency doctor. If not, that's okay. A lot of people make that mistake. That's okay. Um, so let's just clarify. Victoria texted me, and specifically with her text, she wanted to know about my approach to the patient with the anaphylaxis, and she specifically wanted to know how long do I observe those kids after giving them epi, and what is my opinion about giving the other adjuncts, namely steroids and albuterol, for those kids. Um, and I thought it was a very good question because, from what I've learned as a trainee and also as an attending, looking into this every once in a while, is that when you have a child with anaphylaxis, EpiPen is a must. And everything else is kind of necessary, maybe, but not so much. One of my attendings in residency used to say that Benadryl and steroids for anaphylaxis just help the hives and nothing else. He did used to give it, but he was very adamant that it doesn't do anything for the respiratory distress or hypotension and all the serious stuff of anaphylaxis. And that was kind of my approach always. I usually give them, but I never really felt very strongly about it. Tell us, Victoria, with regards to those questions, how important are the Benadryl and the steroids? And with regards to the observation period after anaphylaxis, what did you find?
Yeah, so the bottom line is that, like you mentioned, there's not enough clinical studies available on it. That's probably because epinephrine itself is so widely accepted that there's no real need to investigate the others. And the experimental design itself would be very difficult thinking about it. But for the most part, we still really don't know the significance of using antihistamines as an adjunct treatment to anaphylaxis specifically. However, that being said, a lot of the papers did highlight a common theme, and that sort of supports what you were saying that you learned from your attendings and training is that they do have a significant effect in treating the skin or cutaneous manifestations of anaphylaxis. And so one of the papers I looked at that was published in 2000 by Lin et al., basically, they published data from a randomized double-blind placebo-controlled trial that basically supports the use of combined antihistamines in the treatment of acute allergic syndromes. They didn't specify what they meant by acute allergic syndromes, but they did emphasize that this is on the basis of targeting improvement in those skin manifestations. And so another paper that I looked at was a 2007 systematic review by a group in England. They sought to answer this question as well, but they were unable to make any clinical recommendations for practice. And that's again because they stated that there's not enough randomized controlled trials that have been done, and these would likely be difficult to design and execute. And so it seems like the addition of antihistamines is mainly based on provider preference, with some anecdotal evidence of possibly alleviating discomfort in some patients, but again, that varies patient to patient, and so that's not even a guarantee. I wasn't able to find any overwhelming support for the use of corticosteroids as a first-line treatment, although they are a mainstay in a lot of allergic syndromes. Their use as a primary or even close secondary treatment in anaphylaxis is not widely supported.
I guess that really goes along with what I learned in residency. That, from what I understand from your little research, is that the antihistamines really help the skin manifestations, which is nice, but I would argue not necessary when you're having difficulty breathing and possibly hypertension. And goes along with the fact that steroids are nice, but by all means, not before epi. Would you say that's correct?
That was definitely the overarching theme. In terms of albuterol, that's pretty much recommended to be reserved for the event that you have anaphylaxis alongside with an asthmatic exacerbation, which is what we would expect. So another article that I looked at that was published by Dr. Adam Cheng in 2011, he actually touched on the role of many of the medications that we had questions about. So that was a really good article to read. And he basically, again, restates the point made by other articles that the antihistamines have a proven effect in localized urticaria. So they're a possible adjunct in the context that you want to make the patient feel better and relieve sort of the rash, but they do not have a significant effect on the main symptoms of anaphylaxis, which is what we worry about, the hypotension, that type of thing. One point that I did find particularly interesting in his paper that I wanted to run by you and see what your take on it is that he says, although corticosteroids play an essential role in the treatment of many allergy-related diseases, despite their slow onset of action, they likely provide little benefit in the acute setting. However, most experts still recommend their use, is what he said. So I was wondering if that's something that you've found to be true in your clinical experience.
Yeah, so that's a very good question. I think it's really important to keep in mind in the context of anything that steroids, the way I phrase it, steroids never help the ER doctor. Okay, so if I have a child in anaphylaxis, I need improvement right now. And or if I have a child with an asthma exacerbation, I need improvement right now, especially if it's a severe asthma exacerbation. So I don't think of steroids as something that helps me slash the patient now. It's something that I always do, knowing that it's going to help the patient in a few hours or only maybe in a day or two. So essentially, every child with an asthma exacerbation, I always give steroids, but I don't expect the steroids to show me an effect or alleviate symptoms right now. I would say, though, that with regards to asthma exacerbation, we do know that early administration of steroids correlates with early discharge from the pediatric emergency department. So we all, try to give steroids and we try to give them early. But again, it's not something I expect to have any effect within a few minutes, not at all.
Okay. So, yeah, he basically stated that most experts recommend corticosteroids as an additional therapy just because they're unlikely to harm the child, and they could show some benefit in recovery from it. So it's more of a why not line of thinking, which is also something that you tend to repeat to people who train with you, that if there's no harm in it and it may make them feel better, then why not?
Yeah, do you remember the exact rule?
Mm.
That's okay. That's okay. So the way I phrase it is when you have nothing to lose, you can only win. So some steroids, some Benadryl, no harm done.
Okay, and the last one that the paper looked at was glucagon, which again seems to be reserved more so when patients are concurrently taking beta blockers, in which case they would be refractive to the epinephrine, they would be persistently hypotensive, in which case you would be giving glucagon as an adjunct, really to reverse those cardiovascular manifestations, not necessarily to treat the anaphylaxis. So, in summary, Dr. Chang basically stated that epinephrine remains the most important component in treating acute anaphylaxis and should never be replaced by other agents.
Yeah, so that's actually a really, really good point. I don't believe I've ever seen a child on beta blocker in anaphylaxis. But I gotta say, this question comes up, I think, a lot on the USMLEs or the pediatric emergency medicine boards because it's something you gotta know. And if I recall correctly, it has to do with the fact that if you're giving someone with the beta blocker epinephrine and all of his beta receptors are blocked, his alpha receptors are left open and he's going to get severe hypertension, which we don't want. So that's actually a really important thing for me to remember that if I have a child who's taking beta blockers, which is not very common, and he happens to be on anaphylaxis, which I hope will never happen, I got to think about glucagon, which I got to be honest, I don't think I've ever administered glucagon. It's not something I'm very comfortable with and know the dose of, but yeah, obviously you can look that up quickly. Just important to have that option in the back of your mind. So that's a really good point.
Yeah, it definitely sounds like a recipe for disaster, but at least knowing that you have that tool in your back pocket, if you ever were presented with that, I think was a good outcome of doing this research.
Absolutely.
The next two questions that we had was how long is the appropriate observation time,
Yes.
and how necessary is admission when a second dose of epi is given. And so what I found basically is that currently there's no validated clinical predictors for biphasic reactions, which would be when the patient, of course, has another anaphylactic reaction. But it seems to be that most tend to occur within the first 4 to 6 hours. And so a reasonable length of observation is 4 to 6 hours.
Again, that kind of correlates to what I learned as a trainee. Once you give an epi, you got to keep the kid in the hospital in the ER for another 4 hours. So that really sounds familiar.
In the same paper, Dr. Chang basically stated that kids who have comorbid conditions like peanut allergies or asthma or other atopic scenarios, they are more likely to have a biphasic reaction. They're more likely to need overnight observation. And so these pediatric patients should likely just be considered for overnight admission.
So that's another very good point. I'm not sure when I see a kid with anaphylaxis, I think it's so easy to be focused on anaphylaxis and forget that he also has asthma. And if he looks good, kind of send him home, no worries. But so that paper basically mentions that if you have comorbidities, specifically, I guess they say specifically peanut allergy and asthma,
Mm-hmm. Yep.
you really should consider observing the child. Yeah, so that's actually a very good point, a very
Yeah.
important point for someone like me to know. So yeah, excellent.
So the main conclusion out of everything I looked into is that there is not enough established controlled clinical studies to prove the use of additional agents such as antihistamines, albuterol, glucagon, corticosteroids, other than the specific scenarios we talked about. That the treatment of acute anaphylaxis should mainly be done with epinephrine, with the others being more so an adjunct treatment. And as you mentioned before, I don't think it's realistic for any doctors to be treating it alone with any of those other agents. But there has been some small benefits that we talked about with the addition of the other ones.
Excellent. So that really strengthens or supports what I learned as a trainee. Please correct me if I'm wrong. IM epi is a must. The sooner the better. And then albuterol, H1 blockers, H2 blockers, steroids. Sure, why not? Probably just helps the rash, which is not insignificant. We want the kid to be comfortable, but by all means, not first line. By all means, not single lines. We need to make sure the kid gets IMEPI. That kind of
Yeah,
makes sense.
yeah,
Yeah.
exactly.
What about, so I guess, so those are really, actually, really important points. And I know there's one more paper that I came across that I mentioned to you. Want to hear your opinion. In 2016, I believe a paper was published in Pediatric Emergency Care, basically emphasizing that even physicians and healthcare workers apparently don't have enough of a low threshold to give the IM epi. It's something that we always worry about, the side effects and whatnot, but it's super safe and super important for those kids. And please correct me if I'm wrong. I always tell the parents, if you think you need to give it, you probably should just give it. It is not a whole lot to lose to give it if the child wasn't in anaphylaxis. Sure, it's going to cause some tachycardia, but young, healthy hearts can deal with that, and it's fine. If there's a chance this is anaphylaxis, you're better off giving it than not. Do you agree with that?
Yeah, so in reading that paper, it sort of seemed like the biggest barrier to physicians giving epinephrine and giving it early is that fear that you talked about. A lot of them haven't gotten adequate training in giving epinephrine. And so that was something that seemed to change dramatically after the guidelines were established in 2006, I believe. Yeah, in 2006, they were established. And since then, the number has increased significantly, but there's still a lot of physicians that are sort of nervous about the side effects of epinephrine, and that sort of delays the administration of it, which obviously confers a more prolonged clinical course.
Awesome. Very good. So I think we can kind of summarize that apparently I got good training that was evidence based, right? Thank you for all my mentors in Massachusetts and in Pittsburgh. That again, when you see a child with anaphylaxis, if you diagnose anaphylaxis, get get on the IM epi as early as possible, and then sure, give steroids, give albuterol if needed, give antihistamines of any kind. Observe the child for at least 4 hours, and if the child has other comorbidities, and if the child has severe picture, severe presentation, consider keeping him in the hospital for observation. Would that say that's pretty much summarizing it all?
Yeah,
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 that's great.
definitely.
So, I think it's important to remember, Victoria, and hopefully, probably you'll come across this if you do research in your future career. Sometimes your research doesn't find any new findings, just supports what you already know, which is not insignificant. That's important to kind of support us in what we do. Thank you, Victoria, for doing this. Excellent job. I think it will be great if in the future you come up with more questions like that and we can look into those topics and hopefully get more information about them. This is a very important topic. Thank you, Victoria. Excellent job. Let's do this again sometime.
Thank you so much.
And thank all of you guys out there, PEM Rules fans. I appreciate it. I hope you enjoy the show. I hope you tune in next time. Feel free to reach out with any feedback at pemrules.com. I would love to hear from you. Have a great day.